Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. My lecture today about female sexual dysfunction. So, what we wanted to know about female sexual dysfunction? First, we wanted to know about sexual response cycle, then the definition of female sexual dysfunction and the prevalence, then the classification of FSD, and starting by the hypoactive sexual desire disorder, then continue to female sexual arousal disorder and female orgasmic disorder, then continue with sexual pain disorder or penetrating disorder like vaginismus and dysporonia, and then sexual aversion disorder, and finally we wanted to know about female sexual dysfunction and the menopause. Let us start our journey with sexual response cycle. Please look to this picture. We have 5 phases here: the desire or libido, excitation, plateau phase, orgasm, and resolution phase. Desire start and modulated by the balance between dopamine sensitive excitatory center and serotonin sensitive inhibitory center, and desire or libido stimulated by vision or verbal stimulus. Then excitation start with excitation or arousal phase started with parasympathetic nervous system stimulation. There is enlarged clitoris, there is prevaginal arterial dilatation, there is expansion of the inner two-thirds of the vagina, there is also breast enlargement and the erection of the nipple, the inner third of the vagina increasing length to accommodate the male organ. Then the plateau phase in continuation is considered continuation of the excitation phase. This is the plateau phase. Then the orgasm happens with contraction of the pelvic floor muscles, increase in heart rate, respiratory rate, blood pressure. The outer third of the vagina congested and they become tight. There is contraction in the feet muscles. There is flushing, feeling of pleasure with orgasm. Then we end with the resolution phase. So this is the phases of sexual response cycle. Okay, please look to this curve. This is the excitation or arousal phase. This is the plateau phase. This is the orgasm phase, and this is the shortest of all phases, and this is the resolution phase, as you see. In these curves, this is considered the excitation phase, this one. Continuation of excitation phase is called the plateau phase. This area is the plateau phase. Then this is the orgasm. This is the resolution phase. But the female can have more than one orgasm. 2 or 3 orgasms can happen, yes, but not in male, only in female. Then resolution phase. Sometimes there is disorder and there is no orgasm. The female passes the cycle without orgasm, as in the blue line here. Excitation happened, plateau, but not reaching orgasm, and the resolution happened. So this is abnormal, of course, if there is no orgasm. To say this cycle is completely normal and complete satisfaction for female should include all phases: excitation starting from libido and the desire, then excitation, then the plateau phase, then the orgasm, then the resolution phase. Okay, after knowing the cycle, we wanted to know the female sexual dysfunction. It is defined as a sexual problem, refers to a problem during any phase of the sexual response cycle that prevents the woman from experiencing satisfaction from the sexual activity. As we mentioned before, five phases, libido or desire, excitement, plateau, orgasm, and resolution. What about the prevalence of female sexual dysfunction? Sexual dysfunction is more prevalent in women, 43%, than in men, 31%, and the increase as women age. And some authors suggest that it may reach up to 60%. You should know that many cases pass unnoticed of sexual dysfunction for different reasons. FSD is associated with various psychodemographic characteristics such as age, education, poor physical and emotional health. About 40 million American women are affected by FSD. We should ask ourselves this question: why common but underdiagnosed? Why common but underdiagnosed? Because partly patients are not likely to discuss it with their physician unless they are asked, or sometimes they are ashamed to answer questions related to this. The other side for this problem is obstacles in physicians themselves. Lack of adequate training and confidence, a perception that there are few treatment options, inadequate time to obtain sexual history, underestimation of the prevalence of sexual dysfunction. So look to this table please, and this is the classification of female sexual dysfunction. As you see, we have, according to the phase, either impaired sexual desire or impaired sexual arousal or orgasmic dysfunction, related to orgasm, or penetration disorder or pain-related disorder like dysporonia and vaginismus, or others like sexual phobias. In impaired sexual desire, there is a lack of interest in any sexual activity, and this is the commonest of all dysfunction disorder. Inability to maintain vaginal lubricant until sex act is completed despite adequate physical stimulation. This is the impaired sexual arousal. What about the orgasmic dysfunction? There is persistent or recurrent delay or absence of orgasm after normal excitement phase of sexual activity. What about the penetration and pain disorder like dysporonia, which is persistent or recurrent pain during sexual intercourse? Vaginismus, which is the violent reflex spasm of the lower vaginal muscles, the lower third of the vagina, gluteal muscles and adductors of the thigh on any attempt of sexual intercourse, making penetration impossible or very difficult. So let us start with the hypoactive sexual desire disorder, which is defined as persistent or recurrent deficiency or absence of sexual desire or receptivity to sexual activity. It is considered the most common sexual dysfunction in women. The disorder peaks in women in age 40 to 60 years and in those have undergone surgical menopause. In this age group, it may be situational, such as depression or chronic disease, for example, adrenal insufficiency or endocrinological disorders, or it may be associated with medication use. However, it is more often an isolated event. But in younger women, female sexual dysfunction is often associated with situational circumstances, such as dysfunctional relationship, depressions, chronic disease, gynecologic disorders, and use of certain medications like selective serotonin uptake inhibitors, oral contraceptives, and corticosteroids also. The appropriate treatment depends on the underlying etiology. Psychotherapy and antidepressant for patients who have associated anxiety. Transdermal testosterone can be tried. It is also effective for short-term therapy. However, there is little evidence to support long-term use longer than 6 months because we are afraid from the side effects on the liver and heart and virilism. Generalized and lifelong low sexual desire suggests the need for screening for endocrine disorders, chronic illness, or long-term medication use. This is very important to search for. What about the female sexual arousal disorder? Can be defined as inability to complete sexual activity with adequate lubrication. It often affects women with gynecologic or chronic medical condition and those who are taking certain medication like selective serotonin reuptake inhibitors. The disorder typically resolves when underlying condition is treated or the medication is adjusted. What about the orgasmic disorder? It can be defined as persistent or recurrent delay or absence of orgasm after normal excitement phase. It can be either primary or secondary. In primary, the patient has never achieved orgasm. In secondary, there is underlying etiology. The primary orgasmic disorder may be genetic and is often associated with history of trauma or abuse. It typically doesn't resolve without treatment. Psychotherapy and the couple counseling may be helpful for women with primary orgasmic disorder associated with abuse. Unfortunately, there is no effective therapy for unexplained primary orgasmic disorder, in which the patient has never achieved orgasm, even through masturbation. What about the secondary orgasmic disorder? Physical causes of orgasmic dysfunction may include pelvic or spinal surgery or trauma or use of certain medication like antidepressant, antipsychotics, typically resolve with treatment of the cause. Adjunctive education on masturbation techniques may be helpful in some cases. What about the sexual pain disorder or penetrating disorder like vaginismus and dysporonia? Let us start with vaginismus, which is defined as recurrent or persistent involuntary spasm of the muscles of the outer third of the vagina that interfere with sex. Also may be associated with contraction of the gluteal muscle, adductors of the thigh, making intercourse impossible. It is common in women with hypoactive sexual desire disorder and in those with sexual aversion. These disorders often have the same situational and psychosocial causes and resolve with treatment of those causes. In other women, vaginismus is associated with gynecologic disorder use of certain medication, chronic medical conditions, and the resolve with treatment or adjustment of medications. What is the most effective treatment? The most effective treatment is a combination of cognitive and behavioral psychotherapy known as systematic desensitization. Patients are taught deep muscle relaxation techniques, which they use a while dilators of increasing diameter are gradually inserted into the vagina. Please look to this picture. You will teach the patient to use the dilators. These dilators of different sizes start with a smaller size. The patient do it by herself, insert it inside the vagina. She will feel that there is space in this area, and she will lose the fear of intercourse with the insertion of these dilators with increasing size. With use of this method of treatment, with time, the patient will lose the contraction which occur automatic during trial of intercourse in case of vaginismus. When the patient uses this dilator, this contraction in the lower third of the vagina will be removed. So, it is one of the treatment of vaginismus. But if she tried to do this and failed, okay, refer the patient for pelvic floor physical therapy. What about dysporonia? Dysporonia defined as recurrent or persistent genital pain associated with sex and not caused exclusively by lack of lubrication or by vaginismus. Is a common problem in postmenopausal women. Pain on vaginal entry may reflect provoked vestibulodynia, inadequate lubrication, or vaginismus. Physical examination will reproduce the pain when the vulva and the vagina is touched with cotton swab. If you put cotton swab on the vulva or vagina, the patient will complain of pain. If you insert your finger during BV examination, the patient will feel pain. Okay? So, in this case, there is pain during BV examination, also during intercourse. Pain may worsen over time because of arousal disorder and the loss of desire. Anatomic factors associated with dysporonia, such as scar tissue, PID, pelvic inflammatory disease, vaginal stenosis or endometriosis, which is a very common cause of deep dysporonia, often improve the medical or surgical treatment. Dysporonia may be superficial if the pain occurred during insertion of the male organ at the start, or deep dysporonia if the pain occurred during intercourse or at the end of the intercourse. Different causes for superficial and deep dysparonias. Usually the superficial dyspareunia related to anomalies or lesions at the introitus, either inflammation or mass or ulcer or vulvodynia, while or narrowing introitus, while deep dyspareunia related to pelvic lesion like endometriosis, pelvic inflammatory disease, prolapse, RVF uterus, and so on. Pain of diffuse long-term nature is more difficult to treat. In such instances, referral for psychotherapy may prove beneficial. What about treatment strategies? It includes reliance on non-coital sexual expression, counseling focused on less painful coital positions, the use of antidepressant to treat chronic pain syndrome, and the anxiety reduction through behavioral modification. What about sexual aversion disorder? It can be defined as persistent or recurrent aversion to and avoidance of genital contact with sexual partner. It is much less common disorder. The woman here hates any sexual contact with her partner. She hates the intercourse or any sexual contact. Okay? Low sexual desire and occasionally vaginismus or dysporonia usually accompany it. Women with this disorder may have history of sexual or physical abuse. They may have extensive negative, unexpressed feelings about their relationship. Specific aversions that are phobic in nature, such as aversion to semen, may be difficult to overcome. Although it is rare, some women may have a phobia from semen. That's why she has sexual aversion disorder. This table shows you some therapeutic options for treatment of female sexual dysfunction. As you see here, the idea of using drugs either for peripheral or vaginal clitoral increase blood flow by using prostaglandin, by using PDES, by using nitric oxide, by using VIB, or hormonal treatment like estrogen or testosterone or synthetic one like tibolone, or working on CNS like dopaminergic agents, and there is many examples of these drugs here and the mechanism of action, you can read it. What is the indication for referral of a patient? If a physician with appropriate training in sexual medicine can manage many cases of female sexual dysfunction. However, some cases need referral. What is the indication for referral? Of course, I mean for referral for specialists, other specialists in different specialty. Indication for referral in cases of young patient with history of pelvic or perineal trauma, patient with anorgasmia due to traumatic pudendal neuropathy or hysterectomy, patient with aortic aneurysm or bulbosacral disc disease that requires neurosurgical intervention, patient with genital pain due to neuromas or vestibular adenitis or myofascial pain syndrome, patient with complicated psychiatric or psychosexual disorders like refractory depression or transsexualism, patient with complicated endocrinopathies, forensic reasons, occupational or iatrogenic injuries, patient or physician request for specialized evaluation. What about female sexual dysfunction and the menopause? Actually, estrogen affect sexual performance through what? Through maintenance of genital tissue and the secretions, pelvic muscle tone and the ligaments, and the elasticity. So estrogen play a role in sexual intercourse, as we mentioned, in maintenance of genital tissue and secretions, pelvic muscle tone, and elasticity. What happened in post-menopausal women? Decreased estrogen level induce vulvovaginal atrophy, as you see here in the picture. This is the childbearing age, and this is the menopausal age. Atrophy in the vagina and the vulva here, which may lead to pain and the trauma during sex. So, vaginal application of estrogen results in improved dysporonia, less vaginal dryness, improved vaginal mucosal maturation indices, and reduced vaginal pH. And you should know, because oral forms of estrogen may not alleviate vulvovaginal atrophy, topical formulation may be preferable. Yes, so topical here is much better than oral estrogen. Topical like what? Like vaginal application of tablet, gels, cream, and the vaginal ring, and all of them effective. As you see in this picture, this is Primarine gel for vaginal application containing estrogen. Okay. The optimal duration of treatment hasn't been determined, but daily treatment for a few weeks, maybe 6 to 8 weeks, has been advocated, with gradual tapering based on symptoms. What about androgen level? Androgen level in menopause, the androgen level in women in general decrease during reproductive age until menopause, after which no further decrease. So androgen during childbearing age decreasing gradually until reaching menopause, then become fixed, no more decrease. Many studies have shown that sexual desire and sexual activity increase with androgen supplementation. However, the result of other studies have been equivocal. So what are the forms of testosterone? Transdermal testosterone is an effective short-term treatment for hypoactive sexual desire disorder in women after menopause. What is the main risks? The main risk is associated with androgen therapy, hirsutism, acne, virilization, cardiovascular complication, and complication on the liver. A possible association with breast cancer also has been reported. So you should, if you prescribe transdermal testosterone, you should be careful because of the hazards of its use. Lastly, despite the high prevalence of sexual dysfunction, we said it is reaching about 40%, and in some studies they said from 30 to 60% of women are affected. In women, there are very few centers worldwide that practice comprehensive and multidisciplinary investigation and the management of sexual dysfunction in women. So, we are in need for multidisciplinary investigation and the management of sexual dysfunction in women, because as we see, it is very important disorder affecting the woman life, and it has a high prevalence, as we mentioned, ranging between 30 to 60%. So we should do care and encourage the multidisciplinary investigation and the management. And this is the last slide. Thank you. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.